Welcome to the NeuroMarvels. This is episode number 8. I'm Dr. Gwen Palafox, a neurotypical psychologist who really wants a Diet Coke.
I wish I could hand this to you through the internet.
I
know. That's another thing Gwen and I in common. We're both kind of Diet Coke freaks. Yeah.
Yeah.
It's
that
flag proudly.
Yeah.
Sure.
Yeah. That's one of the our identity factors, Dana.
Yeah. There you go.
Sorry, I derailed Dana's intro. Dana.
No, I am Dr. Dana Waters. I am an autistic psychologist who loves Diet Coke as well. So, and we like to have fun, as you can tell. Yeah.
Yeah, we do. We do. Today, we wanted to talk about a topic that, Dana has some real expertise in many ways. And we felt it was important to share with this community because I think this is an issue that gets glossed over or diminished often.
Yeah.
And that is co-occurring medical issues in our neurodiverse community. I don't know, Dana, what do you
I think that what's interesting about it is there are things that are common to humans that autistics tend to get. And then there's these really weird things that autistics tend to get that do tend to get diminished, like, oh, that's so rare, that can't be you, blah, blah, blah. If I had $1 for every really rare thing that I had going on, and I found one the other day reading an old cardiac echo that I have a bicuspid pulmonary valve instead of a tricuspid one, and the functioning's fine, but I'm like, well, there's another, and it even said in there, this is incredibly rare. It's 1 in 100 million people. And I'm like, there I am again. So anyway, it does tend to, you do tend to get things sort of pushed off because people just think they're really rare, right? Or people get the, it's all in your head thing.
You're exaggerating or something.
A lot of these kinds of things manifest in ways that are not typical, or people just aren't good at describing them, as we've talked about before, with putting words to things. And I still, when I go to a doctor's appointment, especially if it's a new doctor, I get so nervous and I want to get through my list. And, that whole kind of, again, that colonized model of the doctor is the expert and you only have 15 minutes and how are you going to get these things dealt with and so on. But there are a handful of what we call co-occurring medical issues with autism, meaning that they tend to express genetically together. So that's something that is relatively new in understanding. And the idea of neurodiversity itself, right? 20 years ago, neurodiversity or autism was like, it's in the DSM, it's it's the refrigerator mother thing or whatever, what crazy
childhood
stuff.
Schizophrenia, I don't know.
Yeah, 20, 30 years ago. And then a lot of research was done and saw that the neurology is actually different in autistics. And then someone's like, the neurology is actually different. That's interesting. That's like a physical finding. Could this actually be something that's medical? So the idea that autism is a medical neurological issue emerged. And now we're starting to, with the Human Genome Project, they are starting to be able to pair what we call alleles, or different ways that dominant and recessive genes can express themselves, that tend to express themselves or go along with genes that will express themselves if autism is something that sort of has enough genetically to manifest itself. And there are some main ones, right? The first one we think of that's probably the scariest medically, that could really put someone in a lot of danger, is an epileptic seizure disorder or epilepsy, which means you have recurrent seizures, right?
Yeah.
In fact, a lot of people will be diagnosed with a seizure disorder before they know they're autistic sometimes. And if your doctor knows you're autistic, especially if you're younger, that ought to be something that you're watching the warning signs for. And then there's different types of seizures. There's the seizures we see on all the medical shows, what are called grand mal seizure, where someone's doing the shaking. And that's not the only kind of seizure that can happen. There's all these other kinds of seizures that people can't even see. What we call petit mal. So grand mal in French is big, grand. Mal is bad, so big bad. And petit mal, which is small bad in French, are these seizures that are like absent seizures, where a kid will be in class and they'll just be like, and teachers will notice these. Their face will kind of go flat, and then all of a sudden they'll do one of these things and like they'll lose a chunk of time, and that can be what we call an absent seizure. You can also have these smaller seizures where maybe just a part of you gets rigid, or you feel like you're having a muscle contraction or something like that. Those can all be seizures and early signs of seizures. So seizures are something that are very serious, and anybody who has a seizure will usually be followed up with a neurologist to get to the bottom of why that's happening and whether or not they're going to recur. So a lot of autistics have a full-blown what we call epilepsy, meaning they have recurrent seizures and likely have to be medicated for those, right?
Yep.
And there's all kinds of things that can help precipitate seizures, stress, and these kinds of things can make the risk.
Temperature.
Hot temperature can make all the
Yep.
risk go up for that.
Hydration. Like there's
Absolutely.
all of
Lights,
these. Yeah.
strobe lights can set off a seizure, and strobe lights at a
Mhm.
club, you think, yeah, those are strobe lights. But if you're, for example, watching a train go by, that can be a strobe to your eye, and it can actually precipitate seizure. So if
Mhm.
you have those kinds of things and you have that seizure disorder, that's something you would learn a lot about on how to control them and not continue to have them and so on. And if you're going to have a seizure in a place, the number one most dangerous thing about a seizure is falling. So if you stand with your feet together and your arms by your side, and as a human, you fall straight back just on your own body weight and you hit the back of your head, you can die from that impact. So with a seizure, that's the scariest thing, is someone's head protected. So like I've seen people in public that, because I have medical training, I'm like, that person's having a seizure. First thing I do is go over and help them get to the ground and protect their head, right? So that's the most dangerous part of having a seizure, when no one else is around. Don't put your hand in their mouth. The idea of swallowing your tongue is a bit of a fallacy. You want to put them on their side in case they aspirate or vomit, because they can aspirate on that. That's the main thing with that. But those are all things that if someone has a seizure disorder and they're coming to you as an adult and they're autistic, they're usually going to tell you that, or you're going to see the medication that they're on for that. They should be on some sort of medication. Some folks have seizures when they're kids who are autistic, and you can outgrow them. Other people don't have seizures as kids, and then they get into adolescence and they start having seizures, and sometimes they end at the end of adolescence, and sometimes they pervade into adulthood. So it just gives you an idea of how much the brain is still changing and how that can still happen. But that's the number one thing that we're going to talk about medical-wise with autism, because it has potential for so much danger, and you could literally die from it quickly, right? Other ones that are sort of lesser known, or that you see co-occur, and there's some debate about whether or not these are actually on the autism gene itself co-occurring, like we think seizure disorders might be, or that if you have these 5 or 6 genes that tend to express autism, these tend to go along with, right? And those are things like dystonias. And what that means is things like your blood pressure, your heart rate. If you're sitting for a long period of time and you stand up, how quickly does your body respond to that to make sure your brain's getting enough blood? Or do you get faint when you stand up? That's what we talk about with dystonias, are 3 times greater in autism than they are in a neurotypical population. And a lot of doctors don't know that. They're learning about that. GI issues are the other really huge one that I see with folks. And aside from like texture and eating things that you can see, it's more about like GI issues. So something called gastroparesis, where the stomach itself doesn't empty fast enough. And there's tests for this. They make you eat. I've had this test. They have you eat this horrible radioactive egg sandwich, and then they have you come back at different intervals to see how long it takes to get out of your stomach. And for most people, about 90 minutes is kind of the longest something stays in your stomach before it empties out into your intestines. And if it's longer than that, you can be diagnosed with gastroparesis. So there's things that medications they can give you, and ways to eat that can help that. But there seems to be a larger than the neurotypical population incidence of whether it's celiac disease, which I think a lot of people know about. There's a gluten reactivity that causes a lot of inflammation in the body. And then you can have gluten sensitivity, which isn't celiac. You're not having the small bowel involved like celiac does. It's a gold standard to diagnose celiac. But you are having things like other inflammation. Joints can get inflamed. You can actually have skin sort of things. You can have general fatigue and that kind of thing with eating gluten. And I really think this is what was driving the big push about 10 years ago for everybody that had an autistic kid to take them off of gluten.
Yeah.
Just to see. And the idea, again, is that idea of the stress bucket. If that's something going on, take more water out of the bucket. If it helps, great. Even if that person doesn't have celiac or doesn't have gluten sensitivity, it might help. It's worth a try. The other huge thing that we see, the incidence is much higher in autistic folks, and it's about twice as much in autistic folks and up to 10 times as much in women or female autistics, and that's what's called hypermobility. And this is the diagnosable version of that, and it's called Ehler-Danlos syndrome, or EDS, which again is a very rare disorder in terms of the general population, and it's got a bunch of different subtypes. I think it's 7 or 8 different subtypes. Some can be scary. Some can actually it's a connective tissue issue. So the collagen in your body isn't made and maintained the way it should. So people tend to have like really elastic skin. Joints can be hypermobile. So if you have a severe version of it, you can your shoulder can come out from moving too fast. I've known people that have had it to that degree. My ligaments and tendons, I have EDS, tend to be hyperlax. In hindsight, I've had 21 surgeries in my lifetime. All but 2 of those are probably mostly tied to EDS. I've ripped my ankles, my wrists, my knee, my back. All that stuff is because of EDS. And finding out that I had that and knowing what was going on was such a relief, because I'm like, oh, I'm not just hyper clumsy, and it's because I'm more likely to hurt myself, right?
Yeah.
There are some scary forms of EDS that if you think you have it, or your doctor thinks that you have it, they would do rule outs for. And that can be that your heart or your aorta can get emboli or can stretch too much. So like I've had a cardiac and an aortic scan. They do an echo, and thank God mine were normal. And they want to make sure that you don't have one of those vascular versions of it, which can actually cause a stroke, or someone can die from quickly. Like one of the things you read in the literature about women that don't know they have this, they get pregnant and they have a baby and they start to bleed out after giving birth, and they don't know what's going on because they have all these blood vessels that are just bursting open because they're not strong enough to hold together. And that can be life-threatening, right? The vast majority of people that have EDS have what's called the hypermobile type, which is that your joints are super lax. Like I can do things that normal people can't do. And I can do this thing with my feet where I can make my feet almost go backwards. Probably people you see like in the circus that are they're probably actually hypermobile, right? And that's a genetic thing that they're born with, they're hyperlax. So we tend to see those a lot in autism, and with increased laxity comes chronic pain. So even if you're not dislocating or sub-dislocating parts of your body, it's hard for your muscles to hold things in place, because your ligaments and tendons are supposed to be the things that hold your joints together. Your muscles try to counteract it and try to do it for it to keep it in place, and that can be exhausting. So folks that have EDS will have repetitive motor fatigue. Like if they do something a bunch of times, and their muscle will just run out of energy super fast, because it's doing not just the muscle work, but it's trying to keep your joint together, right? So that's one thing you'll see. General fatigue in physical exercise with folks is huge with EDS. The thing I mentioned earlier, the dystonias, something called POTS. A lot of autistics have, and again, way more common in women autistics, which is postural orthostatic tachycardia syndrome. It's a really fancy way of saying that your blood pressure regulators don't work the way they're supposed to. So there can be times at which your blood pressure stays way too low. And so all of us can have that. Like if it's a hot day, you're not hydrated, you've been sitting for a long period of time, and then you stand up too fast, we get like that head rush. Everybody can relate with that. This would, normal people, non dystonia, shortly thereafter, their body would go, oh my God, we're about to pass out. And it'll constrict your blood vessels, try to get all that blood to your brain. And then that feeling of pass outedness goes away pretty quickly. Folks with dystonias or POTS, it doesn't go away. And then, really characteristic, your heart rate starts to race to try to make up for the fact that blood isn't getting to your brain. So that's really characteristic, is your blood pressure doesn't raise when you're upright, that orthostatic, because that means is like standing up. And your heart rate goes up. I think the criteria is at least 30 beats per minute higher than your resting heart rate, and it sustains for about at least 10 minutes out, which is abnormal, right? And more and more of the literature is showing this really is most likely a recessive gene that's carried on those genes that express for autism. We're seeing much more of this now, that people are getting diagnosed with it, and doctors are becoming much more aware of it, right?
Yeah.
So those are kind of the biggies, but the one I didn't mention is sleep issues. That one actually has the highest percent of any of these, probably because any of these can feed into that, right? And we tend to think a lot. We might have a hard time getting our body to relax. It may be the sleep environment isn't cool enough, isn't dark enough, isn't quiet enough. And so every autistic person I've talked to, I think I've met one that can sleep well, a guy friend of mine. Everybody else, it's 75% and up. Autistics will say they have issues with sleep problems, right? So working with sleep hygiene becomes essential if you're in therapy with someone
Essential. I can't tell you, if I was paid for every time I said sleep hygiene,
Yeah.
which, for the audience, sleep hygiene are the environmental and behavioral types of things you do to help
Mm-hmm.
yourself sleep and stay asleep.
And stay
So it's
asleep.
not
Yeah.
just about getting to sleep, but it's about staying
Yeah.
asleep as well.
Yeah.
So
Yeah.
there are protocols, lots of different protocols for that. And
Mm-hmm.
sleep by far is one of the most common complaints that I hear as a therapist.
Yeah, and then
Mhm.
dovetailing off of that, we know, and research in about the last 5 years has shown humans in general, neurotypical, neurodiverse, whatever, if you're not sleeping well, it has a major impact on your health, right?
Yeah.
It's being tied to Alzheimer's formation, it's being tied to dementia, it's being tied
Yeah.
to memory issues. Your immune system doesn't work as well, so you don't recover from illness as well. Tissue repair. There are so many things related to not getting enough sleep and not getting good quality sleep. So you learning about your sleep patterns, what you can and cannot do about them. And like I spend 10 to 11 hours in bed because I'm not a good sleeper. But that gives me enough time in bed that a person, my partner, can get 7 hours and be fine because she's out the whole time, right? I get up
Yeah.
like every 9 minutes and I'm moving around and that kind of thing. So that's something you could really work with a psychologist about, or working with a sleep lab to deal
Yep.
with, right? And you have to take some pretty massive steps sometimes. I have sound dampening foam on the window in my bedroom, and then I have darkening shades on that I have on
Mhm.
with all these little fasteners. Like if someone came in my room and didn't know what was going on, they'd be like, "What is going on in here?" I have 3 white noise machines that I put on, and earplugs, so I don't hear everything. And that is just enough that I'm sleeping probably better than I ever have in my life. But I've had to do all those things to be able to do that.
Yeah, and that's the nod to the sensory sensitivities. I mean,
Yeah.
like,
Yes.
you know,
Absolutely.
I don't remember what episode we did. It's probably our second or third episode about sensory sensitivities,
Sensory.
but
Yeah. Yeah.
that there's more input coming into
Mm-hmm.
your brain.
Yeah.
And so, I think the thing that strikes me with the co-occurring medical issues is the amount of effort and bandwidth that also needs to get used, or
Yeah.
might be used without conscious awareness
Yeah.
on these things. And we wonder why many autistics are tired. Like why
Yeah.
they don't have the endurance to do the things why they might not be able to hold a full-time job, even though they're bright.
Yeah.
These
Yeah.
types of things. So I did air quotes for those of you that are listening and not watching.
It's such
Um,
a judgment. Yeah. Yeah.
yeah, but I just find like the fatigue, like chronic fatigue is very common
Mhm.
with my autistic
Mhm.
adults that I
Mhm.
support, and that is something that they don't kind of understand. Like,
It's part
why?
of what's filling that bucket. If you have these other things going
Yeah,
on, like most of us don't think like, oh geez, if my small intestine is inflamed and I might not even be aware of that. Oh boy,
right.
think about when you're sick, like when you get the flu. What do?
Yeah,
You sleep, you're exhausted because your immune system's in hyperdrive to try to stop what the infection. If you have low level or even moderate level inflammation in your body all the time, that robs you of metabolic energy and like crazy all the time. So yes,
yeah,
absolutely. That expendable energy is already, a lot of it's already gone. And that's that stuff we borrow from the chronic pain folks about how many spoons do you have, right? I've
yeah,
used all my spoons. I don't have any left. Yeah.
yep.
Yeah.
Yeah, and sometimes I've used my spoons to get out of bed.
Exactly.
Like,
On
you
any given
know,
day. Yeah.
yeah,
Yeah.
I mean, and this is a thing that I'm actually seeing in supporting this community is like the definition of disability.
Yes.
And that what's really difficult for the SSI agency or that agent to understand is this concept. Wait,
Yeah.
they can have a conversation. Wait, they can talk to you about what they would do. Wait, they can think about things.
Yeah.
And it's
Yeah.
like, yeah, but that's different. Like
Yeah.
your IQ or your ability to verbalize and reason is different than your adaptive skills or your daily life skills
Yes.
or daily
Yeah.
living skills.
Yeah.
And so like I'm having clients that are getting their SSI removed. And it's like this is not a person that can maintain work.
Right.
They're having a difficult time getting out of bed. A good example, like it's really hot. I'm in Southern California and it's been
Yeah.
very
Yeah.
hot. And a lot of people have these wall coolers or
Oh yeah. Yeah.
swamp coolers,
Not
but they
cool.
are
Yeah.
loud.
Yeah. Yeah.
And,
Yeah.
they've got to turn those on at night because it's so hot, but it's disrupting their sleep now.
Yeah. If
And
they're
so
not used to
now
that.
we're
Yeah. Yeah.
right. And so it's all of these things that we're managing, and it doesn't
Mhm.
matter if
Mhm.
they've got, noise canceling. I mean, this is a person, many of my clients wear noise canceling headphones
Mhm.
24/7. I mean, they don't take them out
Yeah.
of their ears. And
Yeah.
so, adding that is an issue. I mean,
It could
one
be
of
a
my
moving
clients,
target too, and you bring up
yeah,
the idea of SSI,
yeah.
with this POTS thing that, I have adrenal insufficiency as well, which can mimic POTS. And so I've been
Mm,
working with my endocrinologist over the last couple of years to suss out, is this that? Is it not that? It's the increased heart rate that she's like, I think it might be POTS. So part of it is you have to really advocate and do a lot of research and then keep going back to the doctor. But those symptoms can also vary. So you can have someone who's on SSI be able to do 2 or 3 days in a row of work and they look totally normal. And then for the weekend, they can't get out of bed. And
or a
no
week or
one,
2 weeks.
or a week or 2 weeks. Yeah, I'm working on a tiling project that I'm having to do slow because one day I can bang out a bunch of stuff. The other day, after 3 or 4 times of getting on my knees, doing stuff, and then standing up and almost passing out, I'm like, I can't do this today.
Yeah.
Right. So you saw me on the days where I was just motoring through and doing it. Looks totally normal. The day where I was like, all right, I need to stop because I'm going to pass out. Right. So and it takes some time to recover from that kind of episode of that. I think it might have had to do with some of the heat we were having here in Seattle. I just feel like I'm coming out of that. I'm like, oh, I stood up today 4 or 5 times and I didn't feel the head rush. And it made me realize how much I learned to live with that. I know what it's like to take the first 10 steps or something at work, walking to my classroom where I'm like, oh, I'm dizzy. That's not normal, right?
Yeah.
So people do adapt. And then if it's a judging agency like getting disability benefits or calling someone disabled, they're going to say, well, you're not disabled because you can do that sometimes, right?
Yeah.
Yeah, it's crazy.
That's hard. I mean, it's just and that disability, it's this idea that you can lose it or you're not disabled one day, but you are another day.
Yeah, yeah,
That's a really interesting thing there. But it is so often the medical issues.
yeah,
Like
that are
Dana, I
driving
mean,
that. Yeah,
yeah, you went back and you said autism is now considered a medical. What were you?
yeah. A neurological condition or issue, right? It's
Yep,
driven by different neurology.
yep,
And most of these things that I've described, certainly epilepsy is a neurological issue,
yep.
GI issues, the timing of your stomach emptying with that gastroparesis, that's dictated by neurology. It's not your stomach deciding, oh, I'm going to empty. It's all nerve feedback, and that's not working correctly. Some of the other things like being allergic to gluten and that kind of stuff aren't neurological, but can have neurological sort of feedback issues and make someone feel drained that way. So,
Yeah.
yeah, I think it's really helpful that the neurodiversity movement is saying, hey, we're not crazy. It wasn't because our mother never held us. We're dealing with all this stuff. And by the way, it comes with this whole host of other things that can express as well. In that regard, I think it's really positive, and doctors are learning about these things. 15 years ago, if I had gone to a doctor and said I have EDS, now I can go. I have an appointment with my guy to look at my elbow on Thursday, and he says, I see you through the frame of EDS. The way you present isn't like other people, and I'm like, sweet. Even the physical
Yeah.
therapists are like, oh, you have EDS. They're like, oh, that changes everything. So them getting to know all those things about you, and you knowing them about yourself, to me, the whole experience has been so validating. I mean, it sucks. There's a grieving process of letting go, like we talked about in the disability episode, of
Mhm.
not being 100% able-bodied all the time. But it also
Yeah.
really, this is who you are and what you have, and to be able to be loving with yourself around how do I do myself, right? There's a whole process of adjusting to that and getting used to that that you just have to go through depending on one of these things that you have or that you're struggling with.
Yeah.
Mm-hmm.
Yeah. And again, here's this piece of self-knowledge again.
Mhm.
Dana, every episode we've come back to self-awareness, self-knowledge, and
Yeah,
how
yeah.
that is the critical
Mhm.
piece in order for you to advocate um with others. And I find it
Yeah,
to be so sometimes discouraging that the burden of responsibility of advocacy falls on the disabled person,
exactly.
or the person that is wired differently.
Yeah.
And and maybe if that's maybe the role of a support system. How do we kind of ease some of that burden and provide more
Mhm.
advocacy or change policy, or this kind of
Yeah,
thing. But
yeah,
the burden of responsibility does fall on the person who's already dealing with all of these things.
and
So
going back to the last episode we had, we were saying if a therapist fit isn't good, that should
yeah,
go for doctors too. Things are
yeah,
changing. So medical schools are training people now to that the relationship is sometimes just as important, and that if someone comes to you with a whole list of things that they've been researching, yeah, listen to that.
yeah.
If you have a really good collaborative doctor, I have a general care doctor that I absolutely love. It's what's called a concierge medicine, so I pay a certain amount every month, have access to her basically anytime I want. Not everybody can afford that. It's a privilege that I have, absolutely. But she works
Mhm.
collaboratively with me, and I'll 2 years ago, I'm like, I wonder if there's pots too. She's like, yeah, okay, let's go down the path of exploring that. Now I'm just getting to the point now where I'm going to go to a neurologist and have it looked at. But if you have a doctor that's saying, no, I know, and you don't know what you're talking about because you've done that Google search, get another doctor. I've walked out on doctor's appointments. I've waited for an hour and a half in a waiting room after waiting 3 months to get an appointment and have said, screw you, and left.
Mhm.
If a doctor isn't going to respect you in that way, they're not going to work with you. And depending on the kind of doctor you have, that can be a problem.
Yeah.
Neurologists are hard to find. You have to wait a long time to get those appointments. So you're going to be like, oh my God, I waited 3 months to get this appointment. Now I'm finally in there, and they want to spend 15 minutes with you and think you're crazy because you have this whole list of stuff that you've written down. Right. My
Mhm.
experience is the younger doctors get it. Because they're being trained that way, and a lot of older ones just because of who they are and they think it's important. But there's a lot of doctors out there that are just going to treat you really crappy, and
Yeah.
you have the right to say this isn't going to work and I'm going to leave. and then have to wait another 3 months, which totally sucks.
Yeah,
Right?
access, right? Access
Hmm.
to support, access
Hmm.
to services,
Yeah.
access is an issue for sure.
Hmm.
Yeah, I mean, so like, so the, anyone listening, it's just really opening up the way in which you
Hmm.
might see or think about yourself.
Hmm.
And if any of these kind of resonate maybe with
Hmm.
you,
Hmm. Hmm.
or like let's say you've been diagnosed with epilepsy in the past,
Hmm.
that's just part of um who you are, and it's not something you can necessarily control because it's
Yeah.
neurological. I mean, that's the
Right.
point of saying it's neurological or medical. Like, it's what you're wired in that way.
Yeah.
And so um get the help you need, do some research on it,
Yeah. Yeah.
and educate others. And I'm sorry that the burden falls on you.
What's great now, though, again, with the advent of the internet, is that there
Yeah.
are, because if you go to try to read something in the medical literature about seizure disorders or EDS, if you don't, I can usually muster my way through those, but I have medical training and I teach physiology, so I can usually, and even that's hard for me to read. There are so many things out there, especially the things that we mentioned today that go along with autism, that now there's information about them that's really accessible in terms of finding it and in terms of it being written in a way that you can understand, right? So you
Yeah.
can say, "Ooh, God, I totally," they're saying, well, you have, they're using the technical term for what's going on with hyperlax ligaments. And then someone just says, geez, I kept spraining my ankles like every 2 months for my entire childhood. What's that? I kept falling down. They're not going to say it that way in the medical literature, but you go to like Neuroclastic or some of these other awesome places where you can get that information online. They'll say, yeah, I used to fall down all the time. So that's what's great now. And you can go and put it in your language and describe it to doctors. And we didn't have that 20 some years ago. So in that regard, do your research. If you can't advocate for yourself, take someone along who can,
Yeah.
right?
That's
And
right.
if you don't get your needs met, go elsewhere, go to somebody else,
Yep.
because there
And
are
don't
good
stop
doctors
trying.
out there. And don't
Like,
stop trying. Hmm.
don't stop trying,
Hmm.
and I love that idea of, who's in your support system? Can someone in your
Hmm.
support system help you with this?
Hmm.
But be the driving force in
Hmm.
your in the way that you want to be cared for and what you need.
Yeah.
So,
Yeah.
okay. Well, for those of you that have come to the end of this episode, we thank you for being here. If you liked this content, we really ask, and this is only if you like the content, that you like and subscribe or follow and leave a comment wherever you're
Yeah.
listening or watching this. That really helps this channel continue. That lets Dana and I know that we should continue to make these. And if you have any ideas for episodes in the future, we'd love to
Yeah.
hear about them. You can email us directly, or you can leave it in the comments below. And yeah, thanks for being here. We'll see you in the next episode.
Thanks for watching or listening.